Rates of adolescent suicide, which were stable from 2000 to 2007, have increased steadily between 2007 and 2018. These rates further skyrocketed after the onset of the COVID-19 pandemic, which is not discussed in this article, but will be discussed later in the presentation. So as an overview, youth suicide can be described as a spectrum. The spectrum can vary in intensity from passive death wish to suicidal ideation to the formation of a plan to intent to following up on action. Children and adolescents who present with suicidal behavior of any of these types require thorough assessment to determine the most appropriate treatment plan. First is the seriousness of their intent. For instance, a youth who, say, took 4 ibuprofen after an argument with their parents and then immediately told their parents that they did it is, less of a serious attempt than a youth who had a elaborate, well thought out plan with a note written out beforehand, and then they were accidentally discovered and brought to the hospital. Another important thing to evaluate is the underlying risk factors. For instance, a boy who identifies as LGBT, who is bullied at school and who spends most of his time hiding in his room away from his family, is much higher risk than a teenage girl who has a steady boyfriend and is heavily involved in extracurricular activities with her friends. Finally, the strength of the emotional support system. Like I just mentioned in the previous example, the strengths of a youth's connections are key when evaluating suicide risk. A lonely youth is at much higher risk of mental illness and of suicide than a youth with strong social connections. So this is the journal article I chose. It is by Dr. Kurtz and Dr. Levins, who are both board-certified child and adolescent psychiatrists. Dr. Kurtz is the program director of the Child and Adolescent Psychiatry Residency Program at the University of Cincinnati. This journal article reviews and incorporates the data of 40 articles with multiple reference clinical trials and meta-analyses that will be discussed throughout the article, and it was published by the American Psychiatric Association, which also helped fund the research for this article. Okay, so with increasing rates of suicide in youths, making an impact relies on understanding key risk and protective factors. These risk factors may be static and unchangeable, such as a family history or a prior attempt. And if this is the case, it may designate the youth as one that would benefit from more interventions or close monitoring, or they may be directly modifiable, such as isolation or an untreated psychiatric disorder, and direct intervention may be used to target that risk factor to reduce the chance of death by suicide. Major risk factors for youth, as discussed in this article, are prior suicide attempt and self-injury, an underlying psychiatric disorder, being part of a marginalized group, or a family history of suicide attempt or mental illness. So previous suicide attempt is the greatest risk factor and is the most fundamental piece of history to gather when evaluating a patient for suicide, as it seems to increase the risk of death of suicide by more than any other factor, with between a 10 and 60-fold increase in risk. The details of the and circumstances of the prior attempts may also provide important clues, which may help prevent a subsequent lethal attempt. Suicide with a firearm or by hanging are considered especially lethal and should be noted in particular if they're in the history. However, sometimes less lethal attempts may precede more lethal attempts, as the patient may have overestimated the lethality of their previous attempt and will learn from it. All of these are, best taken in the context of the individual situation alongside other risk factors. Finally, non-suicidal self-injurious behavior is a robust predictor of suicide attempts in adolescents and young adults. And even if it's not intentionally to commit suicide, it does have a heavy correlation with eventual suicide attempt. Meta-analyses have found an odds ratio of 2.26. All right. A history of underlying psychiatric disorder, especially when not adequately controlled, is a major risk factor for death by suicide in youths. One meta-analysis of individuals of all ages who died by suicide indicate that mental disorders were prevalent, affecting 82% of youths aged 13 through 19. Psychosis, such as command hallucinations to self-harm, most notably increases the risk, though this isn't common. The odds ratio is 67.5 in an Irish study of a youth who has command hallucinations. Mood disorders, eating disorders, anxiety disorders, substance use disorders, and ADHD also increase risk, particularly when comorbid with other psychiatric disorders. For this reason, a review of past diagnoses and a psychiatric review of systems, including specifically asking about psychosis, is part of the assessment of any suicide risk. Being a member of a marginalized group appears to increase the risk of suicide. possibly related to traumatic experience with stigma that increase a sense of isolation and decrease feelings of interpersonal connectedness, which is very important, as we'll discuss later. In 2017, the Youth Risk Behavioral Survey of high school students found that students who identified as transgender reported a 6-fold increased prevalence of suicide attempts. Students who identified as lesbian, gay, or bisexual had increases between 3-fold and 5.5-fold in prevalence of suicide attempts compared with their heterosexual peers. Although suicide has increased across racial and ethnic groups in the United States, this increase has been more pronounced for Black youths and Indigenous youths, especially in pre-adolescence, with an incidence ratio of 1.82 in Black children aged 5 through 12. Reducing suicide risk among these individuals may depend on finding ways to increase inclusion and equity and ways to reduce the psychological toll of marginalization. Okay. An underlying history of a relative attempting or dying by suicide increases risk of death by suicide in youth. According to data from twin and adoption studies, there appears to be some genetic component likely related to an increased tendency towards impulsivity. This is likely a combination of exposure, trauma, and genetics of underlying psychiatric disorders, like I just mentioned. Other risk factors include a history of childhood trauma and adversity. An odds ratio of 49.3 in one study was shown for young males who suffered abuse. Exposure to the child welfare system and placement outside the home. Presence of firearms in the home. The odds ratio of death by suicide was found to be between 4.5 and 7.2 in youths when there was a gun in the home. Interpersonal loss and conflict. Losses such as the breakup of a relationship or conflict within the family often precede an attempt at suicide by the youth who is already at risk. It often escalates their behavior. Bullying, which is noted to be the case for both victims and perpetrators, and suicide contagion. So this is a relatively recent phenomenon, which may be related to more exposure through social media. It's been noted that there's an increase in suicides after a notable suicide in the news. Also, we've heard before about what happened with 13 Reasons Why, about the rise in suicide attempts after that. And personally, many children I talked to while on my child rotation talked about that they would watch things on social media about methods to hurt themselves, or they learned these things from a friend who had watched them on social media. So I worry that, children who are at risk have too easy access exposure to this. Also I worry that it could possibly be becoming some type of subculture, because there was another child who I talked to who said that they tried to get admitted with a group of friends and all go to the same psychiatric hospital. So I worry that this type of knowledge may be too accessible for children nowadays, which may be possibly contributing to some of this. All right. And of course, with risk factors, you want to talk about the antidepressant black box warning. People worry about it. Early clinical trials detected a higher risk of self-reported suicide thinking or behavior in youth taking antidepressants in controlled clinical trials compared to those taking placebo. And there's concern that the initiation of antidepressants could increase suicidal thoughts and behavior in youths. This has been an area of interest since the FDA issued a warning after those studies. However, recent data has shown this may have been overblown. A meta-analysis of youths with anxiety disorders found that the risk of suicidal thoughts and behaviors were increased with Paxil, but decreased with sertraline compared with placebo. And Paxil is not FDA indicated for treatment in youth most of the time, or it's not what's first line. And although the risk of suicidal thinking or behavior appears low, and the benefits of treating the youth is much higher, patients and families should be informed about the issue when discussing using these medications. All right. Some developmental considerations. So younger children die by suicide at a much lower rate than adolescents and young adults. A nationally representative sample of 11,875 pre-adolescents found that the rate of suicidal ideation to be about 14.33% and the rate of suicide attempts to be 1.26%. This was increased if they were a sexual minority, male sex, or had an underlying psychiatric disorder. And usually this was related, when there was a suicide attempt, it was related to suffocation or hanging. And the second highest cause was death by firearm. And among those, every single one had obtained a gun that had been stored unsafely in the home. So if there is ever an at-risk youth, or even if there's not, it's very important to discuss this with families, the increased risk having a firearm, especially an unsafe one, can have. All right, so protective factors. Most of the protective factors against youth suicide stem from a general sense of connectedness, such as with parents being able to have a trusting relationship and open communication with their parents, other adults, such as aunts, uncles, grandparents, or coaches or teachers, having caring friends who encourage healthy behaviors and who they feel like they can talk to and rely on, engagement and participation in sports, or something else that increases their sense of self-worth and a feelings of accomplishment. This can also be involvement in organized religion or having a sense of personal faith that gives a sense of meaning. Academic achievement can lead to increased sense of hope and confidence. So, of note, these protective factors are often able to be changed. We as psychiatrists may not have direct power over these situations in a child's life, but a parent can potentially contribute to or change a child's situation. So if we know these things, talking with parents and telling them the importance of keeping their child connected or recognizing who they're around is something we can do when otherwise we may not be able to impact this, especially giving the information to parents on how to engage with children who may be engaging in difficult behaviors such as irritability or pulling away, which are signs of depression. If we are able to tell parents how to engage with these children, we may be able to reduce the risk of their suicide attempts. All right, so screening. So with screening for suicide risk, you need to be able to evaluate the capacity to detect indicators of suicide risk, and you need a strategy to evaluate those at risk to determine acuity so that appropriate actions can be taken. And these are two of the scales that are often used. Sometimes they were developed for emergency and inpatient settings, but have been adapted for outpatient settings as well. So one of the quickest ones is the Ask Suicide Screening Questions tool shown on the left. It is a set of 4 to 5 yes/no questions that takes about 20 seconds to administer. It's a negative screen if the answer is no to all 4 initial questions. And if the answer is yes to any of the first 4 questions, you ask a 5th acuity question. Are you having any thoughts of killing yourself right now? If you say yes, then it's an acute positive and needs immediate assessment by a mental health professional. And if it answered yes to any of the first 4 but no to the 5th, it's considered a non-acute positive and needs further assessment, such as the Columbia Suicide Severity Scale rating scale on the right. All right, clinical assessment of suicide risk. So the most important part of the process when assessing a youth for suicide risk is history. In-depth history, especially social history. You need to know the childhood history of trauma, family dynamics, school situations, academics, friends, duration of the symptoms, if they were preceded by some event, such as a history of trauma. You need to know about risk factors, like we discussed previously, such as a past history of suicide and non-suicidal self-harming, psychiatric disorders, substance use, family history, a history of trauma and acute stressors, especially firearms in the home and whether or not they're safe or secured. Also, assess how connected they are. Do they have friends? Signs and symptoms of struggling in youth deserve further assessment include pulling back from extracurricular activities, isolating in one's room, or otherwise withdrawing from family and social interactions, and as well as declining grades. So this begins with detecting and characterizing suicidal thoughts. This can be done with the aforementioned screening tools or to be altered by the clinician based off the situation and flow of the interview. For instance, you ask about the frequency and duration of the thoughts, the presence of a plan, the specificity or vagueness of the plan. It's like maybe I'll jump in front of a train compared to I'm going to overdose on this medication on this date. And then you also would want to ask about the intensity of the plan, the intrusiveness of the thoughts, and if they have any intent to act on it. So, as discussed before, suicidal thoughts exist on a continuum. This spectrum is shown here and proceeds from low risk on the left to high risk on the right. It's nearly universal to feel stressed, like you want to escape from your problems. And this is pretty normal. This would be on the far left. Slightly further along the continuum is feeling so overwhelmed that you feel like death might be advantageous, but you don't actually have any thoughts about doing it to yourself, such as, oh, well, if I just got hit by a train, that'd be okay, but you wouldn't actually think about jumping in front of a train. So this is called passive suicidal ideation. Next on the continuum is having thoughts about suicide without having seriously considered any methods to do it. Progressing along further, they may have considered a plan to varying degrees of specificity, and at some point, they may have considered the plan in enough detail to be prepared to carry it out, such as how and when to access a firearm, or needed how and when to get the pills for a lethal injection. And at the extreme end of the continuum, a patient might have a detailed plan with the intent to carry it out. These individuals are on the cusp and need to be prevented from doing so, usually through involuntary hospitalization. All right. Normally, movement along the continuum is expected to be gradual, which gives opportunities for the patient to reach out, utilize coping skills, etc. However, there's some factors that make individuals at higher risk for jumping from one end of the spectrum to the other. These patients need to be monitored more closely. These factors include impulsivity from substance use, bipolar disorder, ADHD, traumatic brain injury, a significant history of trauma, young age, or intellectual disability. All right. So the early detection and treatment of underlying psychiatric disorders is key to preventing them from worsening over time and for the development of long-term maladaptive habits. And detection of suicide risk necessitates steps to prevent it. And following long-term treatment with a mental health professional can also help reduce risk. So depression is the most common cause of psychiatric disorder that leads to suicide attempt in youth. The first-line treatment for depression in youth is cognitive behavioral therapy, which can help with identifying negative automatic thoughts and distortions and maladaptive schemas. If the depression is moderate to severe, as assessed by screening tools such as the PHQ-9, then pharmacotherapy is recommended. The first-line pharmacotherapy in youth is fluoxetine, which is pictured here, and is often started at a dose of 10 milligrams and titrated to 20 milligrams, which with further increases possible up to a maximum of 60 in depression. Fluoxetine tends to be preferred in youth due to its long half-life, as youth may often forget doses and low side effect profile. While it can have more medication interactions than some other SSRIs, this is often not a concern in young people who do not have other medical comorbidities. Fluoxetine is ineffective. It is recommended to trial a second SSRI, such as sertraline or escitalopram. If these are ineffective, it is recommended to try an SNRI or Wellbutrin. Wellbutrin in particular can be useful as either a primary or adjunct medication in more melancholy depression where patients tend to be isolative and with low energy. Right? So another important part of prevention is the formation of a safety plan, which we often do on the inpatient units before a patient is discharged. The 6 main components of a safety plan include warning signs of a suicidal crisis, internal coping strategies that can be used, people and social settings that can provide distraction, people with their name and contact information who the individual can ask for help, professionals, agencies, and hotlines that can be contacted in a crisis, and ways the environment can be made safe. Involving the family is particularly important with safety plans for children, such as securing or removing firearms or managing their medications, or noticing warning signs, because the patient themselves may not be able to be aware of them as much. So working with the parents is particularly important with keeping a potentially suicidal child safe. So when a safety plan is unable to provide a sufficient level of safety, a higher level of care and other interventions directly targeted at increasing safety may be necessary. This can include inpatient and partial hospitalizations, intensive outpatient treatment, and sometimes treatment specific to suicidal thoughts and behaviors, such as dialectical behavioral therapy for at-risk youth. Right. I've mentioned this before, but because connectedness and healthy relationships with family members and peers are protective, helping encourage engagement activities and with individuals they're close to is very important, through both identifying existing possibilities with the safety plan and improving them and fostering new ones. This is important, especially to reach out to the family and let them know to reach out to friends, because sometimes youth who are struggling with depression may have trouble reaching out. And so if others are realized to reach out to them, then it may make everything more facilitated. All right. So summary of the article. With increasing rates of suicide in youth, making an impact relies on understanding key risk and protective factors. Identifying those at risk, assessing the acuity of this risk, and utilizing interventions to mitigate it are important skills for clinicians involved in youth mental health to prevent suicide. How does the data presented in this article relate to further increases in suicide rates since the onset of the COVID-19 pandemic? Because this study was from 2007 to 2018. What about afterwards? So This is a Japanese study, though similar trends have been noted in the US. Population level data on crude monthly suicide rates from 2016 to 2021 and reasons for suicide in 2018 through 2020 among youth aged 10 through 19 were obtained. They investigated the changes in reasons for suicide as well, such as family related, mental illness, social concerns, and academic concerns. And as you can see in this graph, the red line is before the pandemic and the green line is after. This is a very large increase in trends in suicide among youth. So, according to the data gathered in this study, the reasons of the increase in suicide rates were multifactorial, including mental health issues and disruptions in social relationships. However, family related problems and social concerns were particularly emphasized, which makes sense with everybody having to be isolated during the pandemic, not being able to visit family, not being able to have group gatherings, and not being able to go to school. Rates among youth increased during the pandemic relative to pre-pandemic levels, especially between August and November of 2020, which might be related to the school onset. The suicide levels returned closer to pre-pandemic levels by December of 2020. They remained slightly elevated into 2021. And we observed elevated suicide rates for all the major reasons from summer to autumn of 2020, especially related to family problems and social concerns. And this data doesn't have the later phases of the pandemic, as a lot of that data is still coming out. But just anecdotally, I've heard that there, and seen that there's still a lot in the later phases of the pandemic of visits to the emergency room for youth who are suicidal. Okay, so this is a quote by Dr. Vivek Murthy, the US Surgeon General. As a whole, the loneliness epidemic has been announced as a public health emergency. For adults, the physical health consequences of poor or insufficient connection include a 29% increase of heart disease, a 32% increased risk of stroke, and a 50% increased risk of developing dementia for older adults. Additionally, lacking social connection in adults increases the risk of premature death by more than 60%. In addition to our physical health, loneliness and isolation contribute substantially to mental health challenges. And with more than 1 in 5 adults and more than 1 in 3 young adults living with a mental illness in the US, addressing loneliness and isolation is critical in order to fully address the mental health crisis in America. While the epidemic of loneliness and isolation is widespread and has profound consequences for individual and collective health and well-being, medicine is relatively easy to find. Social connection. That's something that as a culture encouraging more social connection after the pandemic's isolation could help solve a lot of these problems. So this is not just a public health emergency for adults, but for youth as well. Loneliness and social isolation in childhood increases the risk for depression and anxiety, both immediately and well into the future. And as discussed previously, social connection contributes to most protective factors against suicide in youth, while isolating from others and other behaviors related to social withdrawal are particularly concerning in youth as a risk factors for worsening depression or suicide risk. So, as shown in Maslow's hierarchy of needs, love and belonging are necessary for a person to develop positive self-esteem and a sense of achieving their potential. If someone's chronically lonely, they're not going to be able to advance further in, their self journey, and this could theoretically lead to a sense of despair and hopelessness, as well as difficulty in their careers. This is something that could really impact a child as they're growing up and trying to discover what they're going to do with their life. And this is another quote from the US Surgeon General. There's stigma around feeling lonely. It's almost as if admitting to feeling lonely confirms you're alone, which is a vicious thought distortion that's not necessarily true. And for adolescents, this is particularly devastating because adolescents are heavily reliant on their peers in the formation of their identity. This is when they're starting to pull away from their parents and try to figure out who they are on their own or with their friends. So this is exemplified in Erik Erikson's psychosocial theory, identity versus role confusion. Adolescence is the time where humans try on multiple different hats. It's an important function before their identity stabilizes into one that can form deep relationships in the intimacy versus isolation stage, which begins in later adolescence. Loneliness for adolescents could lead to the incorporation of distorted negative self-concepts, such as being unlovable, into the process of identity formation. This could possibly cause deep-rooted anxiety and hopelessness in their future intimate relationships. In severe cases, it could theoretically prevent the formation of a stable identity at all, which may lead to an underlying personality disorder. So it's very serious that, these youth are feeling so lonely. It's a vicious cycle. Isolation can lead to fear, which can lead to rejection, which can lead to social withdrawal and hypersensitivity in relationships, as well as excessive reassurance seeking. All of this can lead to further rejection, and then this can create negative perceptions of the intentions of others, that other people can't be trusted, that other people could never like you. School avoidance from this could lead to academic failure, which could lead to further school avoidance. And this could create a sense of hopelessness for the future, a sense of letting everybody down. And all of these factors can compound on each other to create a downward spiral that they feel powerlessness to stop. They may feel intensely guilty. They may believe they're a burden. They may believe others are better off without them. It just could keep spiraling down into something that, may result in suicidal behavior. So, what can we as psychiatrists do? So, first, we are doctors. We can treat the underlying mental disorder. We can provide psychotherapy or refer to a practitioner who does. We can prescribe pharmacotherapy if necessary. Safety planning. Safety plans involve everybody. Family matters here. Higher levels of care, including involuntary hospitalization, are a last resort, but are necessary if somebody is in imminent danger of hurting themselves. I personally believe that in combination with CBT and pharmacotherapy, a change in situation that breaks this vicious cycle and leads to the possibility for new connections could be particularly impactful. Well, the data on pharmacotherapy alone is not particularly striking. In combination with therapy for learning new skills, it could help stabilize a child and give them energy and internal drive enough to make lasting changes in a new situation. After a change, this may prevent them from so easily falling back into their old habits. This could lead to a newfound sense of hope, which is very protective against suicide and can create a new positive upward cycle of new connections, new opportunities, instead of a negative self-destructive one related to isolation. And as it's pictured, education matters. Just letting a family know what's going on, that there are treatments, can work wonders. Letting a child know that this is not their fault, that their changes can be made, and that they are not doomed can be everything. Combating negative thought distortions, helping children recognize these are negative thought distortions and not the truth, can give them a whole new perspective and can give them a sense of hope. That sense of hope perhaps is the most powerful medicine we can offer. Finally, we can make a difference not just as psychiatrists, but as people. This is knowledge that can be applied to our own lives. We can keep an eye out for the youth in our own lives, recognize signs that non-mental health practitioners might not. We can be involved parents, aunts, uncles, cousins, and friends. We can connect with them as humans, or we could encourage our own youth to reach out to a kid they notice is struggling, that seems like they might be lonely. And as seen in this data, this could literally save someone's life. Thank you. If anybody has any questions, you can let me know.
There's a question in the Q&A.
Yeah, I see. I'm going to answer it. So A lot of this in the later stages of the pandemic is, new data is still coming out for it. But I personally suspect that with the pandemic over, yes, I do believe suicide rates are likely to decrease. Though I do think that it'll be its own journey to help youth who formed certain maladaptive habits over the pandemic, working through those. And I do think there will be chronic underlying mental disorder formation from all of this. Any more questions?
I believe you may have gotten off easy.
I guess so.
I don't see any other faculty or upper levels to be invited into its discussants. So we give it another 30 seconds or so and call it a day. Raise hands or otherwise indicate if you wish to be recognized.
So I see that the question about the subculture. I think that our role here, this is again something that's upcoming new. I think our role here is awareness of recognize what's going on, because I'm not sure if it's always recognized. And I do think that having that awareness, talking with parents about getting involved with that, and potentially trying to initiate a change in situation when possible. Because I do think that, a subculture that romanticizes mental illness, and if that's where they find their identity, that's going to potentially cause a lot of problems down the line as they enter adulthood, and things work differently than they do when you're a teenager with regards to the mental health system. I don't think that that's something that would be easy to directly talk to the patients about, though. I think that that's something that would have to be discussed with, parents about trying to mitigate the potential impacts of that.
Any other questions or comments? All right, thank you for your attendance. Everyone, Happy New Year, and we'll see you in January.
Thank you. I appreciate your coming.